Welcome back to the Zach Clark Show. These next two episodes are going to be about wisdom. I'm so excited because I have someone with us today who is, I consider a friend. He's someone who's had a great impact on my life. I've known him my entire life.
Wow.
I'm very good friends with his son, who's also a cardiologist, and we're going to get into all of that. Dr. Sheldon Goldberg, who I refer to as Dr. G, is our guest today. And he's been practicing cardiology for over 40 years. Dr. G, what is up? Welcome to the show.
Thank you very much, Zach. It's really a pleasure to be here. And I'm honored that you asked me to appear.
Yeah, no, I think, so my spoiler alert, my father is going to be the next episode. So we're going back to back here. And I promised him I wouldn't ask them how old they are. But there's a lot of wisdom coming in these next two episodes because as the world continues to spin, these two guys have seen a lot, right, Jay? I mean,
yeah. I hope that, when I'm older and have kids and grandkids and they have, that I'm running around and still can wake up and want to do my life in a way that is productive and healthy and helpful. And so I think this is going to be good.
Yeah. So let's just start with a kind of an easy, you grew up in Brooklyn, right? Give us like how you got to medicine, the abbreviated version of why medicine, why cardiology, what was the reason for that? I think it's always noble when someone wants to be a doctor.
Well, when I went to college, I had a very brilliant roommate, and he was a great student. I wasn't that great a student, and his father was a GP in Brooklyn, and he would come up and take us out to dinner, and we were in our senior year, and he said, "What are you boys going to do after graduation?" And my roommate said, "Well, I'm really not sure, Dad." And I said, I'm not sure either. "Well, you should become doctors." "Oh, why?" And he said, "Well, the first reason is you get to work with your mind. It's a scientific discipline. Second, and more important, you get to work with your heart because it's a very human discipline as well. And third, and most important, don't forget this, boys, nobody can ever tell you what to do." And I always tell my roommate now, 2 out of 3 ain't bad, Gary. So,
yeah. Your roommate now being your wife.
No, my former roommate is now a cardiologist.
Your roommate now. I missed that. I thought that was a little joke on your wife, who is also a friend and I love very much. Yeah. So, okay, I'm following now.
My former roommate.
Yeah.
So that's how I got into medicine, from a GP in Brooklyn who was a very inspirational character, making house calls, the human touch. And I thought he really exemplified what he was telling us. So that was it.
And so you make this decision to go into cardiology. I'm always curious, and maybe this is something that I shouldn't ask, but there's always the first operation, right? Like, who is that patient? Right? Like they don't know.
Yeah.
Like, I had a pilot the other day, like, "This is our first flight on this plane." I'm like, "What do you mean it's your first flight?" "It's our first flight flying this specific plane," because they were waiting to gas it up or something. And I said, "Am I supposed to be nervous here? Like, when do you finally, hey, put me in, coach, you're ready to do a surgery?"
Well, cardiology training is very long. First, you've got 4 years of medical school. Then you have medical residency that usually now is about 3 years. And then cardiology training, you do general fellowship for about 3 years. And then if you want to do interventional cardiology, that's another 1 to 2 years. Of course, when I trained, there was no such thing as interventional cardiology. That came about much later. But you get a lot of training using mentors. And once you finish your training and you're out there on your own, I always tell people, you learn more in your first year than you did in the prior 7 years of training because you have to. You're the person. And I have to say, having practiced interventional cardiology for 40 years, when I was doing procedures in my last year, I still felt I was learning every time and would try to do something better, more efficient, and more elegant for the next patient. So it's a learning process. Very important to be around people and colleagues that you can ask for help. It's not a sign of weakness to ask for help. It's a sign of strength and confidence to ask for help and other opinions. And in my career, as I started, I had people working with me who were more experienced, and I would always have them scrub in with me, help me out in terms of decision making, and also in terms of technique. So you continue to evolve. But certainly the first time you face that patient alone and you're in charge, it's a big step, and one that I'll never forget. I also kept a biography of all my patients.
Oh, wow.
In terms of what I did. So when a patient asked me, how many of these have you done, I could tell them. How successful have you been? And I think that's very important. And obviously, when I started out, I was not nearly as confident as I was in my later career. But it was still a learning process, even after 40 years.
Amazing.
What's different now or from back then, like in terms of going to med school?
Yeah.
How did you, was it just I'm going to this school and you applied and you got in, or what, how is it? Because I know it's incredibly cutthroat and.
Yeah, I don't know if I could get in today if I had to apply today. I think it's really competitive. And again, my roommate and I decided, since he was such a good student, we'd go to the same school because then he could help me out. And it came down to a choice of a couple of really good places, and we chose the University of Pennsylvania because of its reputation, and it was a very laid-back place at the time. It's the first medical school in the United States, by the way.
Really?
First medical school
Penn.
in North America, Penn, yeah. So our choice was between Penn and Johns Hopkins, and we decided we'd pick the University of Pennsylvania.
I want to go back a little bit just because there's a couple things that I really remember about you growing up. And the first was you were always the joker. I mean, like in my parents' group of friends, Dr. Goldberg was the guy dressing up, on Halloween and banging on your window to scare the shit out of the kids. And like, I'm sure there are kids in Haddonfield, the town we grew up in, to this day that still think of you in those moments. And then there's just another amazing story where my brother Matt had his driver, he was going to get his license. It was a driving test, and it was his birthday's in January 8th. So there was a huge snowstorm. The thing was scheduled. And Dr. Goldberg, there's no way a driving test, we're talking 3 feet of snow, right? Like, there's no way a driving test was happening. So he prank calls my brother. He calls our house and says, this is when there's landlines, and says, can I talk to Matt Clark? And he puts on a voice, and he tells my brother, sir, we're looking at the schedule here. Like, you didn't show up for your driving test. And my brother says, what do you mean? And you're getting your driver's license. This is like the most important moment in your life to date. He says, oh, sir, we don't cancel driving tests for anything. Rain, snow, sleet. And it looks like we're not going to be able to reschedule you until July. And so my brother hangs up the phone, and my parents are in the other room, and he goes into them white as a ghost, says, I missed my test and now I can't. And this was all you. And so, like, I'm just curious, being a doctor, it's so serious, it's so heavy. Where did you learn that playful side, or was that always you? Or
I think it just came naturally. I think, you are under stress when you're doing life-threatening procedures, life-saving procedures. And I think it was probably
that's a great reframe.
A great way to let off steam and have a good time and laugh. And, when you're doing medicine, you're doing it for a purpose. You're doing it to make people's lives better. So you need to have a side of your life that appreciates the human side. And I think, to me, it's very natural, to tell you the truth.
Right.
I still do it, And
yeah, it's amazing. And the second thing I remember is we summer down in a town called Avalon in Sea Isle, which is down on the Jersey Shore. And I remember, this was probably 1992, 1993. You probably remember better than me. And our parents said, put on the news, Dr. Goldberg, who I knew you as just my parents' friend, is going to be on television. And at that time, for someone to be on television that you knew as a little kid, you are amazed. Like, oh my God, my parents' friends is going to be on TV. And it was in relation to your work around the stent. So I need to know, in the not so humble way, your involvement in the stent, how you brought that to market, and really the impact you've had on the medical community through that work.
Well, I think it was the highlight of my medical career to be involved. And again, I was in the right place at the right time. The treatment for coronary artery disease in patients who needed to have their blood flow restored years ago was coronary bypass surgery, which is a major operation, involved splitting of the sternum, taking veins out of the leg, and using a chest wall artery to bypass blocked arteries. And then in the 1970s, a Swiss cardiologist by the name of Grunzig was working with a whole different idea, radical change. Why do we need to split the chest open to take care of a little, 3 millimeter wide artery with a little blockage in it? And can't we thread a tube into the heart and use a little balloon to blow up the area and open up the artery and restore blood flow and relieve symptoms? And it was a breathtaking idea. And I had just finished my cardiology fellowship. And I went from Boston to Philadelphia, and I got a phone call saying, there's a guy in Switzerland who's coming to Boston to demonstrate his new technique. If you have any patients that are suitable. Well, we didn't know what was suitable. So I had a patient who I thought might be a candidate, and I flew her up to Boston from Philadelphia. And her
You were working in Philly at the time.
I was working in Philly, and we went back up to Boston, and I got to meet Dr. Grunzig. He flew over from Switzerland, and I'll never forget what he said to me. He looked at the films, and he said, my technique is not developed enough to use in your patient. If something happens to this artery because of a prior history of a previous heart attack, she could go into shock, and it would be a disaster. And he thought we should pass over that case, step back. And he showed me all of the results that he had in Switzerland with his patients. I think he had done about 20 patients at the time. Well, the group went ahead and did that procedure anyway, and it was a disaster. The artery tore. The patient had to be rushed to emergency bypass surgery. But then I had the opportunity to go over to Switzerland and meet Dr. Grunzig there and learn the technique from him of balloon angioplasty. And the balloon was a great new revolutionary therapy because it eliminated the need for bypass surgery in certain patients. But It had two very important drawbacks. One is you could tear the artery and cause it to close and result in an acute heart attack requiring emergency surgery. And the other is the natural scar tissue that formed after this procedure could reblock the artery some time later. So there was an acute problem and a more chronic problem. So we thought we'd need a better solution. And I was sitting in my office in Philadelphia, and I got a call from somebody at Zac and Jay who just started a new company and said, I hear you guys are having a lot of trouble with balloon angioplasty. I think I have a little solution that I'd like to show you. And he came to my office, and they took a little test tube out, and he had a little metallic cage cylinder. First time I'd seen a stent. And he said, if we put this in, this will prop the artery open, it'll prevent it from closing, and if we get a nice big opening to the artery, maybe this is better than the balloon. I said, this is a great idea, let's try it. So we flew down to San Antonio, Texas. I met the guy who developed this idea, Julio Palmaz, back of the envelope drawing, that he developed. And we did some animal work, putting in stents, and then we had to start clinical trials. So we did observational studies, and after a while we did a what's called a randomized trial, which is the highest form of evidence in medicine, where we had half the patients assigned to get a balloon angioplasty and half the patients had a stent put in. And then we brought everybody back at 6 months and a year, and we looked at our results, and it turns out the results with the stent were superior to those with balloon angioplasty. So now we had what we thought was a major step forward. And we published that in 1994 in the New England Journal of Medicine, and it was a big to do. That's probably
94 was probably I was sitting on the.
Was probably that time frame. So
Phillies were probably stinking.
So that was a major advance, and
this is in 94?
94 when we published it, and it was a great experience for me. Well, it took us 7 years. I mean, we started working on stents in the 1980s, and took a lot of patience and a lot of time. And I got to meet the most outstanding cardiologists throughout the world, and it was a great experience for me to work with so many great people. And we organized the trial, and I was lucky enough to be the principal investigator on it, and that was it. So I was in the right place at the right time. I happened to be in my office when the guy from Jay made the phone call, and away we went. Dr. Palmaz, who invented this, by the way, has a great vineyard in Sonoma, California.
You visit.
And one of the great pioneers and one of the great inventions in clinical medicine. So it was great to be a small part of a
And how
large
many of those
enterprise.
do you think you've put in people over the years? I mean,
Thousands. And of course,
are they still using it? I mean, like, I don't know. I mean, are they still?
okay, well, let me tell you about the stent. So the stent was not a silver bullet because they had problems also. You could suddenly develop a clot. Just think about putting a piece of metal inside of a small coronary artery. The body's going to react to that. So clotting of the stent was a problem. And tissue still grew inside the stent because the body heals. If you cut your hand with a little knife, you would form a scar. And the same thing if you traumatize an artery, the body wants to heal and form scar tissue inside. And if you form very thick scar tissue, it could reblock the coronary artery. So we weren't done with that. And later on, the stents are no longer made out of bare metal. They have a metallic framework, and they also have a drug coating that comes off of the stent that prevents this scar tissue from forming. And we also have better drugs that we give in addition to the stent to prevent clotting of the stent as well. And so it took a lot of work on a lot of people's part. And I remember people asked me when we published that paper, "You think you hit a home run?" And I said, "No, I think we hit a double and it needs a single to knock it in." Use a Brooklyn baseball analogy. And that was the development of better drugs and better stents. And I have to tell you that because of the results were mixed early on, there was a writer, an editorialist for the New England Journal who said the development of these techniques is probably futile. It'll never work. Maybe it'll be applied to 5% of patients who need revascularization. Well, now it's the most common coronary procedure in the world. So you've got to face the problems of your technique. You got to realize nothing's a silver bullet. Face the problem, square on, and try to solve it. We don't try to minimize it. So, and I think that happens throughout all of medicine. There are no silver bullets. Every technique has its drawbacks, and you just got to keep working at it until you make it better.
Yeah, I mean, that's something we see in the behavioral healthcare field, especially, is that, with drug addiction or substance abuse and mental health disorders, I mean, there more than anywhere else in the world, I mean, you gotta hang in there. You gotta keep trying and keep loving. And sometimes, prescribed methods don't do anything to move the needle. And then one day it does.
And you also have to realize that these stent techniques, these interventional techniques, surgical techniques, only solve an acute problem that's been built up over years. And similar to the addiction world, you've got to realize the risk factors that cause it and address those as well, which is very important.
Yeah.
I always tell people in training, I can teach anybody how to put a stent in, but it's much more than that. It's patient selection. It's counseling patients beforehand and afterwards to prevent people from coming back to the cath lab. And I also think stents one day will be just one point in history that will be regarded as a primitive technique as we develop better preventive therapies.
So can you just describe plainly what the stent actually looks like when you're putting it in, you know?
So it's a little metallic cage, and it's today it's mounted on a balloon catheter, and it's crimped in the factory. When the stents first came out, we did it ourselves.
Wow.
It's kind of primitive, but now it's crimped very tightly onto a balloon. The balloon comes in various sizes, so you could put it in different size arteries. And when you put the catheter in, you thread it into the lesion, you position it properly, There are markers at the tip of the balloon to tell you where you are, and you inject a little bit dye, and you see that you're straddling the lesion appropriately. Then you have an inflation device. You increase the pressure in the balloon expands, the stent is embedded in the vessel wall, and the drug comes off of the stent inside the vessel wall to prevent this exuberant healing response, the scar formation. But it's got to do it just the right amount. You want a little bit of scar tissue to cover the metal, but you don't want too much to block the artery. And that's taken years to develop, and I think we're pretty much there. The results are spectacular. And also the patients need to be on medication to prevent this
blood thinners?
clotting. Well, they're not. That's an interesting question, too. We used to give blood thinners, a drug called warfarin. And we thought that was the most powerful thing to prevent this metal from clotting off. And it turns out it was the wrong drug to use because it wasn't the coagulation system that caused the clot. It's blood elements called platelets. So we switched over from these anticoagulation blood thinners to drugs which we call antiplatelet agents. And they're much safer, they cause less bleeding, and they prevent this clotting of the stents. And that was first done by colleagues in Germany. They looked at people that they put stents in over 500 patients, and half the patients were assigned to warfarin, half the patients were assigned to an antiplatelet drug. And the patients with the antiplatelet drug did much better in preventing clotting of the stent. Went from about 6% to 1%, which is a very wonderful result. And if you clot your stent, you're having a heart attack. You can either die or have a major heart attack. So a reduction from 6 to 1% is a pretty major advance. So it takes a lot of investigators, a worldwide effort, a lot of cooperation, communication, and pooling of results and understanding how to best treat patients.
So you began in the 70s practicing officially, or when?
I finished my fellowship in 1977, and of course learned much more in my first year in practice than I did in all the previous years of training.
Would you say over the years, is there a general makeup or profile? Like, do you think people today are generally healthier? Or, with the advent of, technology and science and so much more information, how has it changed from the 80s, 90s that, throughout your career in terms of the kind of person that, seeks help, when they seek, how old they are? I mean, have you noticed that or it's random?
No, it's not random. Definitely more elegant therapies and prevention have reduced the need for these procedures such as stent implantation or coronary bypass surgery. And I think that's a natural progression. And I think educating the population, getting them to reduce their risk factors. Your risk factors can be divided into modifiable versus non-modifiable risk factors. The non-modifiable one is genetics. You can't pick your parents, but you can stop smoking, you can reduce your cholesterol, you can treat your blood pressure, and you can prevent diabetes. Those are the major risk factors. And smoking is a terrible scourge and just increases the risk for developing disease, and also the outcome once you do develop disease is negatively influenced by cigarette smoking.
The smoking.
Yeah.
And what about because a lot of what's happening now is there's these almost nicotine lozenges. Is it the nicotine or it's the actual smoke and the...
It's a combination of all of those things. And, if you want to develop vascular disease, look in smokers. And, when somebody came in for treatment with me, came to see me in the office, I could kind of smell the cigarette smoke on their breath. And I knew they would have the worst disease. When I took pictures of what their arteries looked like, it was terrible. And they develop disease not only in their heart arteries, they develop it in their carotid arteries that feed the brain, the arteries that feed your leg, the abdominal aorta. And we call these people vasculopaths. They develop this diffuse vascular disease that's very characteristic of smokers. And of course, the other big scourge is diabetes and prediabetes. And a lot of inroads being made today with medication.
So I read about these people that just, you'll read about 44 years old, drop dead. And I
Yeah.
think about my profile, right? I'm 41 years old.
Yeah.
I'm someone who I think to the common eye most people believe I'm pretty healthy. And I would say to the next person, I'm decently healthy, but I'll smoke the occasional cigarette or cigar. I will use the nicotine from time to time, just for whatever reason, the Zyn pouches or some of these other things that have come into the marketplace. My diet is not tremendous, but I run a lot of miles. I mean, I run 8 miles today. I'll be running the London Marathon this weekend. My sleep is so. Like in that profile, what is the most important thing for me to hone in at 41 years old?
Totally stop smoking. I continue running. I think that's great. Sleep deprivation, that's a big deal. We know now that, good sleep is very important.
Like what's the average hours? I've heard 8, 7.
I think, the more the better.
More the better.
8 hours, I think, is a pretty good number.
What do you
and
sleep
getting
with?
your do I?
What do you sleep every night?
Probably about 6.
6? Yeah.
And getting your LDL cholesterol, your bad cholesterol down is critical. And we have such great drugs now to do that. And
So would you say, because Zach brings up the nicotine.
I'm worried about dropping dead. I mean, I think about that.
Dude, that's why I brought up I have high cholesterol. Sit next to a renowned cardiologist. I think about that all the time. And I smoked in my 20s. I stopped, was nicotine free, then started smoking cigars, every day smoking cigars. I have been sober for 17 years. But I have this relationship to nicotine, and now there are all these things. Zyn, which is tobacco free. So it's basically they pitch it as there's no carcinogens. It's just 6 or 7 additives and nicotine. But nicotine is really the problem on your arteries, right?
there are a lot of problems. I would
us.
break that habit. I would break that relationship as soon as you can.
Okay.
It's a good thing to
Are
break
you
up with. and you'll
open-minded
feel
right
better.
now to stop?
I'm
Are
done.
you?
I'm
You're
done.
done.
I'm done.
He's
I'm
done. We got. We're counting days.
I have one in my mouth. I'm not. I'm not
You're
gonna-
actively. He's actively got.
I have
the
one
nicotine.
in my mouth.
Yeah.
But I know I do. It's scary because I think about it. I know that it's all bullshit. It's bad.
Well, one interesting thing you talk about sudden cardiac death. Half the patients who have a heart attack never reach the hospital. They die at home of an arrhythmia. And a big focus now is how do we identify those patients beforehand? And there are advancing technologies to do that as well. So one day we may want to take people who have multiple risk factors. We used to have to put a catheter inside of you to image your coronary arteries. Now we can look at your coronary arteries non-invasively.
Wow.
Just a CT scanner. And just a little dye injection in a vein. You lie down on the scanner and you get a pretty good idea of what your coronaries look like. And we can actually characterize what plaques are that are vulnerable to suddenly rupture or erode and cause a heart attack. And
Would insurance cover me if I said I want to just go do that because I want to be healthy, or no way?
No, not at this
tried.
point.
They wouldn't do it.
I said I want to go. I have this relationship to nicotine, and I'd like to see a cardiologist. Would my insurance cover it? And no.
So there's nothing preventative. I mean, there's no. In an ideal world, is that part of a physical? I mean, is that part of a yearly checkup?
I think what's part of the physical is your lipid status, right? Your blood pressure, your blood sugar, and a number called hemoglobin A1C, which is a reflection of what your sugar was like over the past month. So I think those are the starting points, and really work on those things. And
But how much is it because I feel like for people who are not doctors and just play Mr. Google doctor and start working
My mom
themselves
is
into
WebMD. My mother will WebMD me to death. I mean, she will.
You can find anything you think to support the anxiety that you're creating, but how much of it do you think really is genetics? I mean, obviously smoking's bad, diet, but at the end of the day, we do see people I've been watching this Celtics documentary. I mean, Red Auerbach was smoking cigars all day, every day, lived, into his upper 80s.
Yeah.
Churchill was smoking 10 cigars a day. I mean, how much of it is genetics?
I think that's a component of it. And, there are people on all ends of the spectrum. It's not that everybody's going to have this disease. Everybody's going to have this bad outcome. But if you average it out, you want to play the odds as safely as you can, right?
Yeah.
Everybody can go to a casino and have, hit the jackpot, but more often than not, you keep playing and the house wins. So I think the prudent thing is to, modify your lifestyle and diet.
And we're seeing it. I mean, I think there's a pretty big push. One of the benefits I've seen just in the social media world, and I know that's probably you're not spending near as much time as I do there, but there's a lot of people out there playing the longevity game, talking about ways to improve your health and your lifestyle. And a lot of that is around sleep and not drinking and really optimizing your life. So, I mean, maybe there's some things that are being done without us even.
Yeah, I mean, I think definitely, like you're saying, modifying your life. What about alcohol? You brought up alcohol. The Surgeon General came out, linked alcohol to cancer, but from a cardiovascular standpoint.
Tremendous effect. I'm glad you asked that question. Tremendous effects of alcohol on cardiovascular disease. One of the major effects is on the development of a very important rhythm disturbance called atrial fibrillation. So drinking is a risk factor for the development of atrial fibrillation. Atrial fibrillation is a leading cause of stroke because when the upper chamber of the heart doesn't contract, clots can form in an area called the left atrial appendage, and people may or may not know that they have AFib, and the next thing that happens, they have a major stroke. Stroke is one of the worst things that can happen to you. It changes your quality of life completely. Not only can it kill you, but your quality of life is decreased. So AFib is a big contributor to stroke, and alcohol is a risk factor for stroke. We have some great treatments for atrial fibrillation in addition to drugs and blood thinners. We have techniques in the cath lab called ablation, where we can actually interrupt the pathways that cause the AFib. If you stop drinking with AFib, your chance of having the need for a repeat intervention decreases by about 40%. So you don't want to go through multiple procedures. You don't want to, which carry risk. People can have all kinds of things happen during cardiac procedures, and it'd be best to stay out of that situation. So alcohol, tremendous effect on the heart in terms of AFib is just one thing. You can also develop a heart muscle disease called alcoholic cardiomyopathy, where your muscle doesn't contract well and you suffer heart failure. So, and it used to be thought, people talked about the French paradox and drinking red wine and so forth.
Right.
And actually, any alcohol at all is detrimental. There's absolutely no benefit to drinking. I'm not saying it on a moral basis. I'm just telling you what the data is. And the data right now shows that even one drink a day is not going to be too helpful to you.
We got
That's
that
outside
one.
of addiction.
That one at least.
I'm not talking about addiction.
No, I know. Yeah. Thank
We got
God.
that one covered. So
just my Zins over in the corner.
I mean, that's where I keep going with some of this stuff, because as a doctor, and then I want to get into some of the personal stuff around my journey, but as a doctor, you sit there and you do these surgeries and you tell people, hey, you have a chance to live a good life. Don't smoke, don't drink, don't eat crappy food. And then they end up back in your office 6 months later or a year later and they've changed. Does the patient follow the direction or not follow the direction more often?
I found the most frustrating is smoking. It's been very hard for me to change people's habits as far as cigarette smoking is concerned. And some people would say to me, well, you keep doing procedures on this guy and he's still smoking. Why don't you just not offer him the procedure? I never felt I could do that. I still try my best and encourage them as much as possible, but it's a real
that's
scourge.
drug addiction. He's been to rehab 25 times. Why are you going to keep? Well, because maybe on the 26th he gets it.
That's one of the most incredible areas. The other is diet. People get addicted. These food addictions are amazing, and but I just keep trying. Keep emphasizing it, sending people to our dietitians. I'm very strict about cholesterol lowering, putting them on the right dose of medication, getting their blood pressure under control, getting their weight under control, and just losing your belly fat is a very important thing because of the inflammation that's associated with belly fat. So people are using the GLP-1 inhibitors right now, injecting themselves. And
What do you think about those?
I think they're important. I think they can reduce cardiovascular events pretty significantly. I'd like to see you do it on your own, right? It's expensive. We don't know the long-term effects yet, but I think it's been a real advance in medicine.
So if I'm a patient in America and there's two profiles here. There's one that has all the money in the world and the best insurance, and the other is, state insurance and not the greatest financial situation. How different is the care that Profile A is going to get versus Profile B?
I'm not an expert in that area. I can tell you that in the socialized medical systems, there's often delay in care, and people get more immediate care in the United States. I think, but the medical system is broken. No question about it. Just getting an appointment is a big deal. We've got insurance companies overlooking you and telling you you need pre-certification for everything. That wastes an enormous amount of time of the doctor. And with the advances in medicine, these advances are expensive, right? The drugs, when they first come out, are expensive. People always ask, when J&J got the approval for the stent, people asked the president of J&J Interventional Systems, how can you charge $1,500 for a tiny little piece of stainless steel? He said, well, the first one cost $100 million, because the development that you have to put into it. So people are always knocking the drug companies, and I agree that maybe they could use their money a little bit more wisely, but drug development is a very important aspect of things. And we don't have access. Let's face it, we don't have access. And I think
we don't have access to the drugs or to the.
Well, the insurance company, when you walk into a doctor's office, you're walking into the waiting room of an insurance company, basically. Right? That's what's happened. And it wasn't like that when I started my career, but it's certainly like that now. And people waste countless hours on the telephone, telling some guy in far off state why you're doing a procedure, and they look it up in a guidebook and they say, well, it's not an indication. So it takes all of the personal touch out of medicine, and I think it's detrimental to patient care. So something has to change in the system, and I would really favor taking the insurance companies out of the picture.
And you said that, and I see this too, that it's very hard to get an appointment and someone who's working a full-time job and doesn't make a lot of money and trying to and raising kids and trying to prioritize their health seems very hard to do. Is there a lack? Are there not enough doctors? What is it? Just it's too expensive.
There's not enough doctors in areas of need. In rural America, doctors tend to congregate in the big cities. Mm-hmm. I'm guilty of that myself. I want to be a specialist. I didn't want to do general practice, and I think that's the toughest job in the world, doing primary care. Yeah.
Primary care.
Yeah, very, very tough.
So I'm going to ask you something about that, because as a doctor, you get all kinds of calls. Some are in your wheelhouse and some are obviously not. So it's 2010, it's 2011. You're one of my father's closest confidants. And I, Zac, am struggling with a substance use disorder, and it's been going on a couple years now, and the cat is out of the bag. And, my dad calls you as a doctor probably at some point and says, look, Shell, I don't know what to do here. What was your response? What was your knowledge of addiction? What was your, as a doctor who's been practicing in this country for many years?
My knowledge was paltry at best. I had very little knowledge of addiction, but I knew you needed serious help. No question about that. But I didn't have the personal background or experience, knowledge of what addiction is all about. I've since learned a lot about this devastating disease, and I know your organization, Release, is really in the same business that I was in, saving lives, and I think it turned out very well, obviously.
Yeah, it turned out well. I am always blown away, Dr. G, that doctors do not get more training at the entry level around this. I mean, like, the numbers don't lie.
Yeah.
I mean, we're losing 100,000 people minimum a year just to opioid overdose. I mean, that's just a starting data point. And we just fail to acknowledge this as a real...
Well, I'll be very honest. I had no training at all in medical school. Zero.
Look what Dr. Paul, we are the last guest.
And I'm not saying that proudly.
No, I mean,
that,
this is where I think impact can be made, right? Because I had a friend recently in the last month that had a surgery, and they were sent home from that surgery, which I am 1,000% convinced Tylenol and Advil would have been plenty. This was not a major surgery with Tylenol 500 or 350 with 7.5 milligrams of hydrocodone in it. So it's a Percocet 7.5 or whatever. Yeah. And it was just unnecessary.
Yeah.
And that it can start. The doctor didn't warn about anything. And this person, like, we were like kind of loosely in touch, and then they stopped taking it, and they said 2 days later they felt kind of gray. And I said, well, you're probably depressed. You're probably feeling a little bit of withdrawal. Yeah. Didn't the doctor explain to you that this would happen? No.
Yeah.
So that's where I get all screwed up on this stuff.
Well, doctors don't do a good enough job in treating the whole patient. There's no question about that. It's true of addiction. It's true of many other things as well. And I think patient education really should be one of our primary goals. And first, we have to get educated ourselves. And I think the medical school curricula are much better today at addressing these issues than they were in my day. It's like a totally different world.
But is it fair to say that doctors don't have the time to actually develop those relationships with their patients because they are so busy? I mean, we were talking a little bit about the work we do prior to coming on the show today. Yeah. And, I was explaining to you the way that we operate, and you said, I would love to be able to have those. Like, if you had a caseload of 10 patients, you might be able to give the family a half hour to 45 minutes a week of education.
Mm-hmm. The practice of the outpatient practice, I spent a lot of my time doing procedures. That was on the inpatient side, but I would see patients 1 day a week. And if I saw 10 or 12 patients, that was a very busy day for me. My son is a cardiologist, and on his days in the office, he sees 20, 25 patients. The pressure for throughput is enormous. And of course, the administrators are looking, you're not being efficient enough. You only have 20 minutes to see a patient. And people end up spending a lot of extra time eating into their home life. They spend extra time writing notes on their computer. Doctors hate their computers. When I had to learn how to use a computer to see outpatients, they sent me to a class. I was like twice as old as anybody else in the class when we adopted Epic, and took me a while to learn how to do it. And 6 months later, the lady who was the teacher in the course came to see me, and she said, you could increase your throughput even more. Instead of taking notes while talking to the patient and facing them, just type it right in on the computer, right in the room, and you'll increase your throughput. And I said to her, Carol, people don't come to see me to increase my throughput. They come to see me because they've got a life-threatening condition. And she said, I agree with you. Keep doing what you're doing. But it's hard. If you've got a patient, 20, 25 patients to see, the pressure is there. You stay later. Then you get pressure. Well, the staff has to stay later because you're taking time to explain things to patients. It's a real problem.
The outcomes are better.
Yeah.
Is that what you meant, though, when you said before we started talking that you feel like medicine has become too mechanical?
Yeah, it's become corporatized.
And I feel like the doctors take the brunt of that because people think, my doctor doesn't care. I'm just a number, and I go in and out, and that's not true, I feel like.
No, it's not true at all. And I think, I tell people that people today doctors today, the young physicians today, have a much tougher time of it than we had. I think there was more time to interact with patients, less time to be second guessed by insurance companies, less time spent on the computer, and more time spent on that personal contact.
Do you think younger doctors are more, because they're coming up in such a world driven by technology, that they're predisposed to being more, crunch, let's burn through and less bedside manner?
And people miss things also, just, things that they should be picking up. Things like the physical examination, I always emphasize, how do we diagnose aortic valve disease? It's echocardiography test. No, you diagnose it by taking a history and doing a careful physical examination. The echo is to tell you how severe it is, but you should pick it up yourself. So people miss diagnoses. Just a simple thing like taking the blood pressure in both arms tells you if you have a blockage in one of the major vessels coming off your aorta. And that can have devastating consequences. And I always ask people, did you take the blood pressure in both arms? Oh, no, I just took it in the right arm. Well, could be very different. Well, if you're rushed and you don't have time, you can miss things. Mm-hmm. No question about it.
That's the same thing with the drug test. Yeah. I mean, in our work, right, the holy grail of knowing if someone's getting high or not is they pee in a cup, and then you dip the thing and it reads whether they're getting high or not. And I always say that should be the last line of defense.
Yeah.
Is this human being acting like they typically act?
Yeah.
Do you smell alcohol on their breath?
Yeah.
Are their pupils dilated? Like, there's real things that we can look at as behavioral healthcare professionals and families. That's why it's so crazy to me, because families will refuse all of these behaviors until they have it in black and white on a piece of paper.
Oh, yeah. I'll ask somebody on rounds, did the patient have bypass surgery? I'm not sure. Did you examine the patient? Yeah. Was there a scar on their chest?
Right.
And, the last resort, talk to the patient. Get that history. And the history is so revealing. And I think we're spending less and less time getting history, doing a careful physical examination, and relying on laboratory data. And that leads to excessive testing that you don't need. A lot of anxiety in patients to go through extra unnecessary tests. And, people talk about artificial intelligence all the time. And I always say, what about just regular intelligence that we use in our, common sense and how we approach patients? And I think AI will be important in some areas, but I still think the personal touch, the attention to detail is, really, really important. And I always tell people, when I finish talking to a patient, examining them, if I don't know what's happening to that patient, I don't know what the diagnosis is, I'll never know.
The thing that's coming up for me is that you spend a lot of time on the heart, working on the heart, the medical heart. What have you learned during your time as a doctor about the emotional heart? Like what allows people to pull through and stay alive in these moments where we think we're going to lose them? Or what have you learned being in that operating room for so many years about the spirit of humans?
I think it's very important to communicate with them afterwards and not take hope away from patients, to give them something to live for, to share your experience in a way that gives them hope for the future. And I think that emotional support is very, very important. And people get depressed after they have a cardiac procedure. I'm not in control anymore. This happened to me. How am I going to recover from this? So I think depression becomes a very serious issue. And depression, of course, can worsen heart disease itself. So the mind, the brain, heart connection is a very important one to deal with. And I always tell people I can teach most people how to do a procedure technically proficient. I can teach them how to put a stent in. But I think much more important is being a complete physician and taking care of the emotional side of the patient as well. And I think that helps with adherence to protocol. If you show that you really care, I might listen to you a little bit more, right? So I think medicine should be a very personal field. I mean, it's the most personal of all occupations. I can't think of another thing that I would rather do with my life. And I know you feel the same way about, we're in the same business, basically, Yeah,
and I think there's something that I struggle with from time to time is I am very much known as the person who, is like this helper, right? And so your profession is in your name, the way that you are addressed, doctor, Goldberg. You know, that's how people know you. And the truth is you're much more than that. You're a husband, you're a father. I know your kids. And I'm just curious, you know, because there's a lot of young people that listen to this show. There's a lot of people that will tune in and for the last 50 some odd minutes have heard you talk very brilliantly around, you know, your work, cardiology and the heart and some of the amazing breakthroughs that we've seen. But I would want to shift gears and kind of ask you, like, at this point in your life, what do you tell a younger doc? What do you regret? What do you not regret? I'm just curious if you have any thoughts sitting there in this chair today.
Life thoughts.
Yeah, life. Just because the world is crazy right now. And you've been through many iterations of this, I assume. Is it crazier than, you know, 40 years ago? Is this normal to you? Do you have hope for us?
I think it's very crazy, and I think part of it is the Pope used a great expression. I had a show about Pope Francis. He said the epidemic of the global epidemic of indifference. And I think we live in very isolated spaces right now. You know, when I was growing up, telephone rang, you didn't know who was on the other end of the phone. It was a sense of excitement. You know, how am I going to respond? You took a picture with a camera, you went to have it developed, and you got it back 3 days later. Now it's instantaneous. You don't have to think about it. Everybody's on their little computer screen, isolated in their own little world. And I think the sense of isolation breeds a lot of bad problems. And I think we see it in young men especially. I think that's a very vulnerable population. And I think the whole idea of a lot of screen time and little human interaction, doing things virtually rather than in person. I don't think we could have this conversation if we did this on a Zoom meeting.
Right.
I really don't.
Right.
You know, I feel the whole thing feels very different to me. And I think a lot of our medical education now is conducted virtually, and a greater sense of isolation there as well. And, you know, when you're by yourself and your mind wanders and you start ruminating on problems, and you can get to a very bad place very easily. But when you have a sense of commonality with other people, I think that's a whole different world. And I think it's important to have a little bit of a work-life balance with your family. I know for myself, I wasn't the best example. I spent probably a lot of time on the work side. I should have spent more time on the family side. Fortunately,
Do you regret that?
Yeah. I watch my son. He's a much better father than I ever was. My daughter's a much better mother than I ever was a parent. Fortunately, I was married to a great woman who, you know, made up for my shortcomings in that area. Yeah, I do regret it. But you know,
Do you think if you would have prioritized family, your career would have been different?
Possibly, but when you really look at the big picture, not in any important way. You know, maybe I would have. Maybe a little stuff happened because of my dedication to my work, or obsession with my work, I should say. Maybe some minor points were enhanced, but I think overall, I think it would be. You know, I admire my son for the way he does it. He's really got the big picture. He's got four little kids.
No, I know, Dave. I mean,
yeah.
But do you think you're a better doctor than he?
No. Definitely not.
So,
I
like
think
the sacrifice.
He is the new improved version, no question about it. No,
I'm not letting him hear that. I'm not letting him hear that.
No, he really is.
But.
And
so
I'm just
you
talking,
sit here
and
again, like
record,
I
yeah.
just
What?
Yeah.
I'm 41, and I sit here and I really think about how I want to spend my time on this planet. And I try to learn from people who have lived more life than me. So now, sitting in the seat that you're sitting in, how do you want to spend the time that you have left? Like, what is important to you today? Because I feel like at this point in your life, that's probably pretty clear to you.
Well, a couple of things are important to me. On the professional side, I retired from clinical practice, so I do a lot of teaching right now of the residents, the fellows, and this Cardiovascular Institute is very important to me for continuing medical education through that nonprofit. That's all very important to me, and I'm blessed having 6 terrific grandchildren. I get the biggest kick out of that. I really, look forward to being with them and getting inside their heads and see how they're thinking. It's very, very refreshing, and I have the time now to do things with them that I really look forward to. I think there are many nights when I didn't come home until very late, and my wife and kids were without me. I think I could have handled that a little bit better. Yeah, just very honest, and I admire the way I watch my kids. They're better parents, and I don't think professionally they're anything less than I was.
Were you thinking that, like when you were younger? No. It was just of the time.
It's a different time. It was a totally different time. It's when I think about how life was back then, I can't even conceive of how it is, right now. Those thoughts never entered my mind. I was so, I would say, driven professionally.
So would you say that we could benefit maybe with taking the mentality of your son as a professional and a father and transplant that back to a time when we all weren't isolated with these phones and technology, and what could life be like then?
That would be the best of all possible worlds, I think. Yeah, I think so. And I think it's important to be around, the right role models too, and having that extra time. When I was a resident, I just had great teachers, and I remember one professor I had, Dr. Castle, who straight out of central casting in medicine, tall, white hair, distinguished, did great research, discovered the reason for pernicious anemia, real, thinker and a great doctor. And we'd be on rounds with him and walk into a patient's room, and he would take out his index cards and he would ask the patient, "May I sit down?" That made it, tremendous impression, because he had, respect. Now everybody's running around, waiting to see the next patient. But he said, "May I sit down?" Then he would take out his index cards, write the patient's history, talk to us, take the time to explain things. And not very common right now. Mm-hmm. We're checking the lab tests. We're looking at the computer screen. Not the best. Maybe we ought to get back to a little bit more humility and taking the time to see our patients as human beings. He was saying, "I respect you.
Yeah,
I'm here to help you, and I'm going to make eye contact with you and listen to what you have to tell me."
But that doesn't provide the instant gratification that every human on this planet right now is searching for.
Yeah.
The phone, the computer, whatever it is that you're doing, that's sending something right back to you. And you might never know how that interaction or that sense of, seeing someone might affect them. You might never know.
Yeah.
Well, is there, because you mentioned artificial intelligence, and, obviously it's like you can't go 5 minutes without hearing it or seeing it or reading it somewhere. Like what in medicine, have you seen the impacts of it, or what are your thoughts on it and how it could be helpful or also harmful?
It's gonna start to have an impact. It hasn't had a major impact yet in my practice, but it will, and I think it can be a very positive influence. But I hope it doesn't take people away from their intuitive skills and developing the ability to talk to folks, to examine them, to look at data in a smart way, rather than just relying on the computer. I don't think that's going to be the answer. I think it can be a very important aid. Mm-hmm. If you look at an electrocardiogram, and I think hundreds of thousands of EKGs, so certain patterns stick in my mind. Well, if a computer can do that better than I can, that's terrific. Mm-hmm. But, we have computers read EKGs right now. First thing I do is fold that piece of the paper over so nobody gets confused by that, and still want to do it myself. right? Don't believe every lab test that comes back. Still correlate it with my intuition and the results I know from talking to people and examining them, right?
And do you believe, though, that like there are young physicians entering, into the world that can retain that philosophy? Because my fear is that like eventually the old, the transition happens and everyone is a walking computer, and forgets that human spirit, to your point.
I think there's a real risk to that happening. I hope it doesn't, but I think there is still a real risk to that happening. And we overlook very obvious things in pursuit of the unusual, But I think it'll be positive development if used properly.
If used properly.
Yeah. Well, I can't even quantify the impact you've had. I mean, the number of lives that you've changed is amazing. We're running short on time, but I do want to hear, just give us 2 minutes on what you're doing now with the nonprofit and kind of paying it forward, and how you plan on riding out into the sunset with some of this cardiologist stuff.
Yeah, well, I go into the hospital. I make rounds 3 times a week with the residents. They present cases to me. We go over the history, the physical examination. I always tell them I don't want to hear what the report says. I want to look at the primary data myself. So we look at the images ourselves. We look at the heart catheterization, the ultrasound findings, the CT angiograms, the EKGs ourselves. We don't look at reports. We look at it, formulate our own thinking. And what do we do next? What's the evidence for what we do next? So that's been a really wonderful thing, for me to do. I feel very happy about that. And I've had doctors tell me after they graduate from our program, now they're in another program somewhere else, and they say, I just saw a patient in the ER. I remember what you told me that time, and we made the right diagnosis and chose the right path. And I remember it was based on that case that you reviewed with us. So if we can, this has a very practical impact. It's not just talking for talking's sake. You're actually going over things in detail that can set people's way of thinking so that patients in the future can be helped. So that's a real positive for me. And we also use this as jumping off points to do research and writing articles on topics that need to be written based off of clinical experience. And then the Cardiovascular Institute is a nonprofit which has been around for about 25 years, and some years ago, in a moment of irrationality, they made me the president of the organization, and I mainly dealt with practicing physicians with years of experience, and I changed it somewhat to look at the next generation of cardiologists. So we run an annual training course for residents and fellows. We have world authorities come to speak to them. We have people present cases to them and use it as a jumping off point for the latest evidence in that field. We use medical simulation. You can come and put an aortic valve in if you like, and encourage interactivity. And I like to select faculty who are not just going to run in and give a 30-minute lecture and be on the plane out. I want people who will sit down and have dinner with these guys and talk to them. We also talk about personal enrichment topics, how to act like a human being in your first year of practice. You're not a rock star, no matter what you think. You're still a servant. And career development pathways, things like that. So it combines personal enrichment with the latest data on cardiovascular disease. We also do case demonstrations, patient presentations, and emphasize the latest treatment options that people are just learning about. So that's been pretty gratifying for me.
I love it. Are you proud of your career?
Yeah, very much so. I have no regrets as far as that's concerned.
Do you feel, and this would be my last thought here, but it sounds like you are just as motivated and energized about the work that you're doing that you were 40 years ago? Is that?
Oh, no question. Yeah.
For you, like, how do you think, what has been like the key factors that have allowed you to maintain that, or why do you think you still feel so energized?
Well, I think it's such an interesting field. It's changing so much. When I was in medical school, the mortality from having a heart attack in the first few months was about 30%. And then when coronary care units came in, it cut the mortality to 15%. And then when we started opening up arteries, now it's about 2 or 3%. I mean, just in a span of 50 years, you've had such major advances, and they continue. We're just
So your
looking at the
curiosity.
surface right now. I think, people always say, doctors always say, well, don't send your kids to medical school. Don't encourage it. I never encouraged or discouraged it. I let, my son take his own path. And I think he feels the same way about it as I do. I mean, there's a lot of enthusiasm and excitement and making the right call, changing somebody's life. There's nothing like it that can give you that much gratification. And I think having finished clinical practice, that's one form of gratification. The other is teaching others to continue in the tradition of excellence. That's how I look at it. So
Beautiful.
I wouldn't trade places with anyone.
Well, this was awesome. I mean, really special for me. I mean, you've been such a big part of my life, and so I'm grateful that you're
same
here.
here. I always say, I knew Zac Clark when.
You certainly did. I mean, wiffle ball in your backyard with David as a
Yeah.
little tyke. So that's going to be a wrap for this episode with Dr.
Thank you.
Goldberg. Thank you very much.
Thank you.
Thank you very much.
Thank you.